I'm a clinician and a user of clinical guidelines who's learning to better apply evidence-based medicine to clinical decision-making. I consider myself a student amongst teachers in this block that we're in the middle of right now. Endocrinologists have an important voice as we make the ultimate decision about whether or not to prescribe any hormone for any condition. Typically, it's an endocrinologist, gender dysphoria included. So over the course of the next 15 minutes, I'm going to run through a brief critique of current guidelines, mostly focusing on the Endocrine Society because that's what most endocrinologists are going to pay attention to. Those guidelines at least have a surface appearance of being actual guidelines in the traditional sense versus WPATH SOC 8, Standards of Care, a misnomer, and the AAP position statement on gender dysphoria. So what we're doing is using evidence to determine best treatment for gender dysphoric youth. That's our focus. Hold on. I got to click twice here. The stakes are high. The Dutch protocol endorsed by the Endocrine Society guidelines results in first the medical and then surgical sterilization of a minor. We could quibble about that a little bit, but I think it's pretty clear. At least everyone acts like that's what happens when you go down this pathway. And then likely sexual dysfunction at all as well due to the fact that puberty blockers halt genital development. So you don't have maturation of genitalia, and this negatively impacts sexual function, orgasm in particular. The Endocrine Society guidelines recommend fertility preservation prior to initiation of puberty blockers. But at Tanner stage 2, there are really no viable methods to preserve fertility because the gametes have not developed. Some may quibble with that, but I think that's pretty straightforward at this point. Puberty blockers really should not be considered a pause button because almost 100% of patients who start puberty blockers go on to cross-sex hormones. I think that's been well established. The logical implication of that fact is that the very first, I spoke about this before, the very first administration of a puberty blocker has a high likelihood of being the first step in a sequential treatment pathway that ultimately results in sterilization or infertility at a minimum. I personally think it's highly questionable whether a preteen minor can understand the impact of transition on fertility, physical health, future romantic relationships, sexual function. And we're learning that reproductive regret may not be insignificant, depending upon how you measure. This is from some of the original Dutch data, longer-term follow-up, up to 20 to 40% of people who underwent transition as youth have reproductive regret. If I skip a slide, will someone just yell at me? Okay. So I'm on to the Endocrine Society guidelines. So we're going to look at specifically the puberty blocker recommendation. So recommendation 2.1, we suggest that adolescents who meet diagnostic criteria for gender dysphoria / gender incongruence, who fulfill criteria for treatment, which is table 5, and are requesting treatment should initially undergo treatment to suppress pubertal development. That's a number 2 suggestion, a weak recommendation based on low quality evidence. That's the 2 circles with the 2 crosses. Recommendation 2.2, we suggest that clinicians begin pubertal hormone suppression at Tanner stage 2, which is very early in puberty. Okay, so this is back to what Yvonne was speaking about. This is a tool that allows users of guidelines to determine if the recommendations within the guidelines are trustworthy. So this is a list of assessment questions from, I call them the McMaster Evidence-Based Medicine team. The first author is Dr. Brignardello Peterson, who I'm not sure if she's here today, but will be with us here tomorrow. This set of questions is designed to help guideline users determine trustworthiness. So I'm going to apply 3 of these questions to the puberty blocker recommendation that I just showed you. And we'll see where we end up. Okay. Okay, so first question, is the recommendation clear and actionable? Sub-question, are the patient's intervention, alternatives, and recommended action clear? And I contend they are not. So management recommendations should be easy to follow, avoid ambiguous language, should be explicit in their direction for or against a recommendation and their strength. They should clearly indicate for which patients the recommendation is intended and which ones might benefit from the intervention or an alternative. So that's all necessary information. So there's a few issues here. The diagnostic criteria for gender dysphoria and gender incongruence are not the same. So one requires distress, one does not. I'm not a mental health professional, but why are we treating adolescents who are not distressed? Table number 5, so back to the recommendation, criteria for treatment, states that gender dysphoria, not incongruence, so it's confusing, must be present and worsening, and that the pediatric endocrinologist must agree with the indication for puberty blockade, despite the fact that endocrinologists are not trained or qualified to make these diagnoses. Okay, are the patients, the definitions are incoherent. So, gender dysphoria. The distress and unease experienced if gender identity and designated gender are not completely congruent. Okay, what is gender identity? This refers to one's internal, deeply held sense of gender. Okay, what is gender? There's no definition of gender provided in the document. Does gender mean sex? What does it mean to have a deeply held sense of one's gender/sex? Why would a patient not understand their sex? There's no meaningful etiology, no meaningful discussion of etiology in this document. Okay. Alternatives, observation, psychosocial support are not discussed. Mental health outcomes, very important. Mental health outcomes of patients who do not transition are not discussed. Maybe it doesn't exist. The guideline authors should state that and explain what to do in the absence of that information. This is critical for an informed discussion with patients. Okay. All right, sub-question B. Is the strength of the recommendation clear? Yes, but asterisks. Okay, so guideline authors, they should indicate the strength of the recommendation and also the certainty of evidence. So a suggest, which is a qualified support, and then evidence, low quality, upon which the recommendation is based. So in this situation, both are presented. We've got a suggestion, we've got low certainty of evidence, but it's problematic to offer a recommendation when no systematic or even unsystematic search and review of available evidence was done. And this will be my next slide. So this is a fundamental fatal flaw of this document. No systematic reviews were done looking at mental health or physical health outcomes from puberty blockers. So I don't understand how you can get to a recommendation without that fundamental information. You're going to miss stuff. Anybody would if you don't do a systematic search through the literature. So question number 2. Was the evidence summarized with rigorous systematic review methods? No. We don't have a systematic review regarding outcomes. There's no explanation as to why. The only evidence provided, there were a couple of systematic reviews that looked at bone health and I think cardiovascular, someone knows off the top of their head, risks, but not about mental health outcomes. The only evidence provided is the observational trial from the Netherlands that we've been speaking about, the Dutch protocol, the 2011 and 2014 studies. There are significant problems with that study. Clinically insignificant changes in mental health parameters were reported, used, I'm going to say an unvalidated gender dysphoria survey, keeping in mind I'm an endocrinologist, not a mental health professional. You all can argue about that. And was at high risk of bias due to confounding, which means there's something else going on that you can't tease out. All the patients received mental health counseling, and also selection bias. As Jenny mentioned this morning, only the highest functioning patients progressed through the study. Okay, quickly about values and preferences. So we talked about this last night, and we'll have more discussion about it as we go through. So our values and preferences associated with the outcomes appropriately specified. So a patient's values and preferences about treatment should be taken into consideration, especially in instances of low certainty of evidence. If it's high certainty of evidence, and most patients are going to decide to take the antibiotic, the values and preferences are less significant. So values and preferences. These recommendations place, this is out of the guideline, place a high value on avoiding an unsatisfactory physical outcome when secondary sex characteristics have become manifest and irreversible, a higher value on psychological well-being, and a lower value on avoiding potential harm from early pubertal suppression. There's no description of how these different outcomes were chosen. Are these patient values or guideline committee values? And then this further raises a concern as someone who's being asked to halt the pubertal development of a child. Can a 9 to 12-year-old at Tanner stage 2, very early puberty, understand the impact of sterility on their future well-being? If not, wouldn't that minor be likely to undervalue the side effects of puberty blockers and subsequent transition, thus undermining the purpose of the values and preferences step? So this is a critical question that I think needs to be answered. This question, amongst others, are important ethical questions that are not discussed in the document. Okay, sub-question C. No, question 4. Sub-question C. So I'm skipping around just for time. So is the strength of the recommendation appropriate? I would argue no. So they make a suggestion for puberty blockers, despite an absence of a systematic review, based on low certainty evidence. And so I'm having a hard time finding someone to explain to me how, when balanced against the harms of transition and the fact that most kids who start puberty blockers go to cross-sex hormones, how does that balance of harms, benefit and harm, not tilt towards a recommendation against? Okay. Question 5. I need to speed up here. So very quickly, are there any important differences between the recommendation question and the clinical question of the patient? Yes. Most of the presenting cases of gender dysphoria today, as we've heard, are not the classic childhood onset. So this guideline deals with the classic childhood onset. So can we apply this guideline to a 16-year-old with no history of childhood gender dysphoria? So my conclusion is that the recommendation regarding the initiation of puberty blockers as presented in the Endocrine Society 2017 Clinical Practice Guideline is not trustworthy. As you can see, this process of guideline interrogation is tedious, but it's necessary to safeguard patients. I was trained in a time when you just accepted guidelines. Well, it's a guideline, and the people who put guidelines together know what they're doing. We should not accept guidelines at face value, and these tools are available and accessible by any clinician. And trustworthy recommendations are essential to ensure patients are safeguarded from harm. So you don't send the wrong patient down a treatment pathway. That's a terrible feeling. And are fully informed before making decisions about their care. Okay, so very quickly about SOC 8. Do I have a couple minutes? Okay, so SOC 8, Standards of Care 8. This is a clinical practice guideline. Standards of Care is a legal term, not a clinical one. So just very briefly, the document promotes access to hormones and surgeries anchored solely on the concept of bodily autonomy and self-determination. The document erroneously states that a systematic review of evidence focused on adolescence is not possible because of scarcity of data. That's not true. This absence of a systematic review precludes them from making reliable evidence-based recommendations. They did commission a systematic review published in the Endocrine Society, one of the Endocrine Society journals, examining the effects of hormones on quality of life, depression, anxiety, suicide, all the outcomes that we're interested in on patients of all ages, and that's referenced. The findings of that systematic review are consistent with the other systematic reviews in this area, low certainty of evidence for these outcomes and inconclusive evidence regarding suicide. I've got 2 slides left. The AAP document, it's a policy statement, it's not a guideline. Systematic reviews are not incorporated. We have to be essentially extremely careful when we're dealing with irreversible health changes when taking recommendations from a document that does not do systematic reviews. So in conclusion, the current guidelines, in my opinion, it's a fact, they're not informed by systematic reviews of evidence in critical areas. They therefore, I don't believe, can adequately safeguard patients. We've got conditional support for puberty blockers, but the guideline users are not provided enough information to determine. I am not provided enough information from that document to determine the positive or negative effects of hormonal interventions on young people suffering from gender dysphoria. And the fact of the matter is we do not have reliable guidelines to guide decision-making for gender dysphoria at the current time.